Welcome to everyone who has joined. We will begin shortly. Just let everybody file in. All right. Thank you to everyone who's joining us today for Aging Services and Long-Term Care in Transition, Preparing for the Road Ahead with our guests Brendan Williams and Irving Stackpole. Irving, would you like to say something?
Just welcome to everybody. Thanks for joining us. Hope this is a vigorous conversation. I'm delighted that Brendan is with us, an insightful thinker. He's written a lot and has established himself as a true authority in the realm of long-term care and skilled nursing in particular. So without any further ado, please, Brendan.
Oh, thank you for that generous introduction, Irving. Remind me to give you the money I promised you for that. But no, it's great to have an opportunity to chat about long-term care here. Obviously, a subject of great interest for us and academic interest for me as well. Next slide, Emily. So, one of the great challenges, and this is something that Irving is going to be addressing, is workforce right now. Here in New Hampshire, we typically have one of the lowest unemployment rates in the United States. And I think, my participation in this sort of lets you get some insight into a state. But I think this is true throughout the United States that we have these challenges. The good news, I guess, is that the workforce shortage since the pandemic began has been steadily diminishing. The bad news is that in the ordinary course of things, since, of course, the pandemic began years ago now, it seems hard to believe that, but it's, 4.5 years. You would actually want to have more staff than what you started out with in February of 2020. So, here in New Hampshire, we have, for example, county-run facilities, which are a remnant of the county poor farm system. So each county has its own facility. For the most part, union wages and benefits at those facilities. I think there's only one exception to that. And those facilities can't find workers. So we have a couple of county facilities that, for example, have had 50 beds offline and a piece, and wait lists of as many as 100 prospective residents. And that's all due to staffing. The facilities are not taking in those that they would not be able to serve. And so that, of course, then jams up the hospitals. And we are in ongoing discussions with our hospital partners here in New Hampshire. And I know this is something that's true throughout the United States over, what can we do in order to ease this situation? Because if a hospital cannot discharge a discharge-ready patient to a nursing home, hospital's not getting paid for that person. And so we've had a lot of emergency department boarding that's been occurring here in New Hampshire. And again, this is a situation that we see throughout the United States, and obviously one that only gets worsened when facilities close, because when a facility closes, very oftentimes it might be in a rural area. And so you're going to jam up that hospital, and it's going to make it all the more difficult for them to be able to discharge to the acute care setting. And it's just also inappropriate. I mean, nobody wants to, with all due respect to hospitals, nobody wants to be in a hospital when they don't have to be, when it's more appropriate for them to be discharged either to a nursing home or to a home and community-based setting. Next slide, Emily. So here in New Hampshire, we have a special problem, and this is, something I think you see also in some other states. But we have an exodus of licensed workers to the state of Massachusetts. Even though I think people look at New Hampshire as a prosperous state, and it certainly is. It's one of those states that's tied for the lowest FMAP on Medicaid, which is an indication of high income. The reality is that Massachusetts pays more to direct care workers, and so we lose them, and we really can't afford to lose them. And so I think a lot of states have struggled with this retention issue. How do you keep your nursing school graduates, for example, in your state? Are there strategies in which you can incent them to stay? We did actually have some legislation that passed this last year to try to address that. In classic New Hampshire fashion, however, the legislation was not funded. So the funding will have to follow. But, it's discouraging when I talk to, for example, a couple of registered nursing students at UNH, and they're working on a project. And so I'm assisting them with access to our membership in terms of finishing their project. And I tease them and I say, you're not going to leave New Hampshire, are you? And of course they are. They're both leaving New Hampshire. And, too often times that's something we see. And it's also a challenge, I just think, for the sector as a whole, that we're playing a sort of a Hunger Games of scarcity right now in healthcare, and that's been ongoing. It was something that predated the COVID-19 pandemic, but it's only gotten worse since. So, for example, in this article that I excerpt, or column that I excerpt, I talk about the vacancy rate at New Hampshire hospitals when they have a 12% vacancy rate for registered nurses and a 22% like what we call licensed nursing assistant, elsewhere you call them a nurse aide or CNA, vacancy rate. We're competing for those workers, and we don't have in nursing homes an insurance, not to get going on insurance and how great it is or anything, but that type of revenue stream that hospitals can rely upon. Instead, facilities are obviously very constrained within Medicaid means as to what they can offer prospective employees. So that's discouraging. And next slide, Emily. It's also why it would have made it impossible had the staffing mandate proposed by CMS under the Biden administration gone into effect. There's some reasons to believe it will not go into effect. But first, let me say that opposition to the staffing mandate is not because we're troglodytes. The reason we're opposed to it is because it's impossible to actually meet it. And so we are the only state in the country that had its two Democratic senators in opposition to the staffing mandate, and one of our two Democratic members of the U.S. House also in opposition to it because they understand this one-size-fits-all approach would not work for a state like New Hampshire. I think people, again, when they think of New Hampshire in the abstract, they might think of it as some sort of bucolic suburb of Boston. The reality is it's actually more rural than, say, a state like Iowa, where I went to high school. We don't have any major metropolitan areas like Iowa does. We have Manchester, and then from there it gets very small. And Manchester is not big. So the population is really diffuse. The staffing mandate also, and this is something I've written about, in op-eds and in a lot of the article, purports to basically amend a statutory law. When the laws pertaining to nursing homes were updated in the 1980s, they were done with great exactitude because Democrats in Congress then were afraid that the Reagan administration might subvert what their intent was. And so they spelled out the statute with a specificity you would typically find in regulation, not in statute. And that's a double-edged sword because that means that you really can't modify that much through regulation, especially now that we see the so-called Chevron doctrine overturned by the U.S. Supreme Court, in which courts where there was doubt would pay deference to the interpretation of an administrative agency relative to a statute. Here, I never thought there was any doubt. I quote here the plain language of the statute. The plain language of the statute says a nursing home is only required to have a registered nurse on duty 8 hours a day, 7 days a week. To say that you can, through rule, require 24/7 coverage just flies in the face of common sense. And also, the reality is that nursing homes, and they can be held to this standard, are required to provide adequate staffing already to serve those they care for. And that can be enforced by state surveyors or federal surveyors without this staffing rule at all. But you may have seen there was an article in the Hill today. There was a recent article in the New York Times. Kaiser Health News has covered this. That the staffing mandate will be rescinded under the forthcoming federal administration. That will not fix the underlying problem that we face of just simply not having enough staff. Next slide, Emily. So one of the arguments in favor of the staffing mandate that really just frustrated me is Xavier Becerra, who is the outgoing Health and Human Services Secretary, had claimed that basically there are no regulations for nursing homes. He characterized nursing homes as the Wild West, which suggests to me, once again, that he just simply wasn't up to his job. He was one of the more invisible members of the Biden administration. But the reality is that the nursing home regulations exceed those that are applicable to nuclear reactors. You probably heard that anecdotally, and I sought to prove it through this visual with the help of a nun at one of our 2-member facilities that serve nuns. The state operations manual for nursing homes is a massive, massive document. I certainly wasn't going to have her hold it. I thought she could lift the lighter of the 2 documents. But, her facility illustrates why the staffing mandate would have been so foolish because we have 2 facilities, again, that serve nuns. One is 22 beds, the other is 24 beds. The idea that they would have to switch from having an RN on duty 8 hours a day to 24/7 RN coverage, well, that requires the hiring then of 2 RNs for each facility to cover an 8-hour shift. And that's just simply impossible. And it's completely unnecessary too. So again, common sense was ignored with respect to the mandate. It's frustrating because, in this last administration, we saw a lot of attention paid to home and community-based services, which I think is very laudable, actually. In the American Rescue Plan Act, there was $37 billion that was given to HCBS, according to the Biden administration. There was only $500 million there for nursing homes, and none of it was for direct care. It was really just for infection control and infection control response teams. ARPA was sort of an act frozen in time because, of course, at that point, we already had the vaccine against COVID-19. So we didn't really need that money. They couldn't really use that money for the purposes towards which it was intended. And so really nursing homes have gained nothing under the Biden administration. There was going to be, in response to a staffing mandate that would cost at least $6 billion a year by our estimation, a one-time grant of $75 million for nursing home workforce needs, which is, I think, if you divided 15,000 some nursing homes into it, that would be about $5,000 per nursing home once, which is about equal to what one of my member nursing homes would offer a registered nurse for a sign-on bonus, one registered nurse. So next slide, Emily. So, the nursing home sector is experiencing a lot of churn since the COVID-19 pandemic began. I think we're all aware of that. Obviously, the American Rescue Plan Act and also just the supply chain difficulties arising out of the COVID-19 pandemic and kind of getting the economy back, created record inflation. And so facilities have had to deal with that. And there's also been a record wage inflation. Nursing homes have, until recently, and I have to see the most recent data, but they've been, they were the leaders in healthcare when it came to wage increases since the COVID-19 pandemic began, on the order of 27% over a few year period of time. And then only slightly exceeded by home care. The last time I saw the KFF Peterson data. The wage inflation has been tremendous. It's not been matched by Medicaid reimbursement. And then we also see the increasing dominance of Medicare Advantage. Now most people this year, for the first time, instead of being on fee-for-service Medicare, the traditional Medicare signed into law in 1965, are receiving their Medicare benefits from private insurers. And not going to go too much into their bad acts, but the bad acts have included denying skilled nursing care through algorithms and certainly underpaying nursing homes when it comes to their rates. Sometimes a Medicare Advantage insurer's rate might be similar to a Medicaid rate, which of course is a money-losing proposition for facilities. And so as we inexorably seem to migrate into this world where Medicare Advantage is dominant, the Medicare offset that has traditionally helped subsidize Medicaid underfunding in states is going to go away. And that is a very scary proposition. And I have maintained that the existential threat to nursing homes isn't so much this staffing mandate, which I thought would go away one way or another, but rather Medicare Advantage. And I still maintain that. Emily, the next slide. So just want to give you a little illustration in the state of New Hampshire as to, what all of this churn has met. I started here in May of 2016, and until the pandemic began, and I guess we have to say it began in February of 2020, but really March of 2020 was the month that will live in infamy for all nursing homes because it's when they were shut down and visitation and various restrictions were put in place. We had only seen transitions really involving three nursing homes. One of my nonprofit members, Catholic Charities, sold a nursing home. There was a private facility that was sold twice. And then the Dartmouth Hitchcock hospital system through the New London Hospital closed a nursing home, which I can assure you they desperately wish they had back right now because they've got people warehoused in their hospital system and they can't get them out. Next slide, Emily. So since the pandemic began, over 1/3 of the nursing homes in our state have been sold. So again, compare my first, 4 years here with the next 4 years. And you go from transitions involving three facilities to transitions involving, more like 23 facilities. And, I think there are some who would say, well, gosh, the fact that these nursing homes are being sold must tell you that it's a profitable business, right? I mean, that's got to be the way it is. And they'll say that that belies, claims of financial exigency on the part of nursing home providers. But really, it's about, who has the deep pockets to be able to withstand loss and be able to play a long game, because demographics are destiny. And I know Irving will touch upon that, but we are an aging society. We are a state with a nursing home bed moratorium, which means you can't open up new nursing homes. And so the idea is, to paraphrase the movie Field of Dreams, people will come, and they will come to your nursing home. And so you just need to wait. You need to be able to wait. And so there are those who have bought nursing homes, assuming that things will work out and assuming that Medicaid rate increases, which we've been successful in getting, will continue. But it's a precarious situation. The financing is precarious. The assumptions being made are precarious. We're going to continue as a society to need to try to address our long-term care funding needs, because we as the federal government certainly has no strategy whatsoever when it comes to long-term care. Each state is on its own, and we definitely feel that in New Hampshire. So with that, I will yield to Irving and come back later for some questions.
Thank you so much, Brendan. Excellent points as usual and customary, and I will indeed attempt to address some of these. I'm acutely aware of the issue you raised at the end of your presentation about the loss of supply of skilled nursing. Just at the end of the pandemic, I set up a Google alert for nursing homes close. And initially I got one a week, one every other week. And then I started getting them every day. And I have some data about the national closure rate. And to your point, the question is, what's the inflection point? What's the point at which the available supply of skilled nursing capacity, beds, is so far below the demand that there's real problems, not just, I'm not saying that stacked up ERs or constipated hospital discharges aren't a problem. This is fundamentally an economic problem. And the problem's driven by demography, basic hydraulics of supply and demand, as well as politics, but I'll get into that. So the future, as you suggested, is driven by demand. It's also driven by technology, because I can't get my cursor to work. There we go. Now it'll work, I hope. It's also driven by supply. So supply has two dimensions in the long-term care arena. The more critical dimension is the workforce, is the labor. And I'll dig into that a little bit. Economics, what are the economics of it? The regulatory aspects, health systems changes, because as much as nursing homes may or may not be part of the healthcare system, I would argue that they are, if there is even a system. But nursing homes are part of that ecosystem that allows sick people, disabled people, particularly vulnerable people, to be cared for. And then we get to talk about what consumer preferences might be. And I can tell you that's a very interesting area where I spend a lot of my time, professional practice. So this is what Brendan was alluding to, and indeed, demographics is destiny. Neither of us coined that phrase, although we'd like to take credit for it, I'm sure. But this graph here, if anybody's been to one of my presentations, you know what it is. It's the graph of live births in the United States from 1910 to 2010. And what we're particularly interested in for purposes of long-term care is the demographic 85 plus, because it's at 80 years of age, and in particular at 85 years of age, where the rate of consumption of long-term care services really skyrockets. I know this from my experience with Kimberly Quality Care as a home care professional. I know this from my experience with 5 Star as a long-term care professional, as well as with rehab companies, et cetera. the rate of consumption really skyrockets. And as you can see, we're coming out of a dip in the live births in the United States. And somebody born in 1939 today is 85 years of age. And you can see that the curve gets very steep. It starts to grow. Why is that relevant? Well, in a short few years, by 2030, we're going to see that the peak of this curve is very much higher than the sulcus, the dip on this curve. This means that there's an oncoming onslaught of demand that has to be satisfied. It needs to be met. It's not quite an age wave as much as Mr. Dykewald and his colleagues would like to say, but it is an increase in demand and one we're not prepared to meet. So I'm going to talk about what the future ager is. They are more diverse. There's far more women because testosterone still kills us guys. The question is their ability to pay. The research is very clear that the income of individuals and their ability to pay outside of Medicaid reimbursements for long-term care services is extremely limited. We have a growing cohort of older individuals who are what is being called ALICE. They're asset limited, income constrained, and employed. Now, historically, this has been a way of sociological research looking at the demography, young demography, to understand their needs. I'm suggesting that in a few years, we're going to be applying ALICE principles of sociological research to us geezers as well. And what we're absolutely going to wind up with is we're going to wind up with an extraordinary number of individuals who are 80 years of age, they're old, and they're home alone. The Joint Center for Housing Studies at Harvard University has speculated with some mind-boggling numbers of the number of individuals who are 80 years of age or older who are at home alone, living in their own single-family dwelling. It's mind-boggling, and it presents both a challenge. I like to say every challenge is an opportunity, but this is a real challenge: loneliness, delivering services, accessing services, and the economics of home ownership and home liquidation. Liquidation of your primary residence is the major source of funds for elderly individuals to finance their out-of-pocket requirements for aging. This is a political, economic trap that is set and is about to clamp itself onto the ankles of every elderly, many millions of elderly people. Anyhow, I won't say anything more about that for the time. Let's talk about a little bit about supply and demand. The inventory of supply, specifically in skilled nursing, but also in assisted living and independent living, which is much more elastic than skilled nursing. Brendan mentioned certificate of need requirements in the state of New Hampshire. 39 states still have a certificate of need requirement in place, which means that you can't build new nursing homes. And who would want to anyhow? So the inventory growth has been about 1.2 to 1.4%. And the age qualified growth, as I showed you the demographic curve, has been about 24%, will be about 24%. Now, you don't have to be a genius at maths to get that that doesn't work. There has to be alternatives. And here's a little more on the housing situation. The reason a prior presidential candidate landed on the number of 3 million new homes or dwellings that need to be constructed is because when you crunch all the numbers, and this was done for me, this is a graph done by another very clever person, not me, but it's very clear that that's exactly the number of new dwelling units that's needed in the United States to satisfy existing demand. Remember that the generations behind boomers and Xers, those two generations are far bigger than we are. and they want a place to live, and they want to be on the property ladder. So here's a critical thing about supply and demand. If you look at the supply of skilled nursing, and here we have the histogram, the bars on this chart, or as I should say, my good Bostonian, the bars on this chart show that from 2015 to 2035, the number of SNF beds decline. Now, this is from data from CMS, and I have simply applied the trajectory to the existing decline. This may actually be steeper. This decline may actually be more severe. The orange line, on the other hand, is an attempt to isolate only the sickest, most vulnerable, and the poorest people. These are the ones who wind up in nursing homes being cared for by that beautiful nun that Brendan had his picture taken with. The neurological, neurodegenerative, musculoskeletal dependent are scheduled to grow at the rate of the orange line, so that by 2030, there is a gap in the available supply and the absolute demand for skilled nursing beds. And on the same trajectory of supply contraction, this gap grows at a very serious rate. Now, what does this look like? It doesn't look like a constipated ER. It looks like people being found dead at home. That's frankly what it looks like. Now, we as a society, I don't want to launch into cultural conversations, but as has been said by others, this was by Bennis, culture eats strategy for lunch every day. Our culture is a giving culture. Our culture will not step over ill and suffering people on the way to our SUV. We will reach down and help them. This gap in supply against demand will create horrible images and horrible news and media stories that will push us into addressing it. Just as I would suggest the assassination of the United Health executive is pushing the public into a conversation about the failures of the insurance industry. I won't say it's a wholesale failure, but the failures of the insurance industry and the regulatory bodies to manage their risk management products. I won't say anything further about that at the moment. Supply is also reflected not just in the inventory of built environments like nursing homes and assisted living in IL, assisted living, independent living, age-qualified housing, seniors housing. That's doing just fine, thank you very much. There's a lot of elasticity in that supply, and it's coming on board quite quickly. If the investment market stays solid, which is another question, it will be elastic, but the skilled nursing supply is terrible. It's the labor that's a real problem. And as Brendan pointed out, the labor in New Hampshire has a twofold problem. One is they could create more nurses and CNAs and med techs and pharmacists, but then they migrate, they leave. So there needs to be policies, political will behind policies that allows the changes in the legislation to get funded, or that allows things like anti-poaching agreements between and among states. There are ways to do it. It's been done before. In the late 70s and early 80s, the United States did this with engineers and with other limited classes, important workforce categories where there was severe limitations. It can be done, but there isn't the political will, and I have a theory about why that isn't there. But as we can see, the United States has not yet recovered from the contraction in the available labor supply. The other part of this picture that we need to take into consideration when we look into the future, because this is a conversation about the future of long-term care, is the secret supply of workforce. That's this unpaid workforce. This is me taking care of my mother, you taking care of your aunt, my son taking care of his grand stepmother. It's us being Americans and being willing to step in and help and not step over people in need. This is a huge part of the economy. And everybody that's taken a shot at measuring this is highly biased. So you have to take their numbers with a grain of salt. But it's been estimated in the trillions. And I don't think that that's unrealistic. The high end of the number might be a little high, but certainly it's over a trillion and maybe as much as 1.6 or 1.7 trillion based on my back of the envelope sort of calculations. The other social issue around long-term care is that the society is changing. I'm the leading edge of the baby boom. Brendan is the back edge of the baby boom. How popular is loneliness? That question is intended to be, It's intended to be provocative. Because loneliness, just before the pandemic, people were talking about how loneliness was the new smoking. It's a public health hazard. The risks associated with failure to socialize are profound. And yet, culturally, we don't accept the congregate solution. We don't accept the solutions that are right there at our doorstep for reasons that we in our industry, and I've been in the industry since 1985, after I left the hospital business and the DME business, I've been in this, and we have failed to change the conversation or the metaphor about long-term care. It's still faulty towers. It's still God's waiting room. It's still ugly, smelly, and I don't want to go there. And that's just wrong. It is a few of those things sometimes, but most of the time, it's exactly what we need, and that's human contact. So how popular is congregate care and how well is your solution accepted? In New Hampshire, the penetration rate of purpose-built seniors housing is only about 9%. Get that. It's only about 9%. That means only 9% of the age, income, and otherwise qualified individuals accept a congregate solution. Well, I'm a pioneer. I'm tough. Well, you're going to die alone being that tough. Sorry. Okay. The other issue that's going on here in the background, and this is bigger than long-term care, is that health systems are consolidating. Remember, health systems are like the aircraft carriers in the healthcare system, ecosystem of the United States. Long-term care providers are like the tenders, that the boats that pull up next to the aircraft carriers and send over some bread, and they send back their disposable items and stuff like that. Long-term care is small compared to hospital systems. So we have to pay attention a little bit to what's happening there. And they are consolidating. This is bad from a number of points of view, and it's driven by a very curious phenomenon, and that's the failure of regulation to include long-term care in meaningful use. And if anybody is interested in that subject, there's I think it's great. I've done a webinar on this very subject, and it's on our YouTube channel. But this consolidation is having an extremely deleterious effect on long-term care. It's having a crushing effect on peripheral providers. So if in a marketplace area, if you're not the preferred provider, the preferred home care provider, the preferred hospice provider, the preferred SNF provider for a healthcare system that just acquired all of the competitors in its marketplace area, if you're not the preferred provider, you are up a creek without a proverbial paddle. So this is something that is another feature of the marketplace area. Now, I've also want to let you know that I've included some references in the PowerPoint. Please go ahead and take a look at those. But I wanted to, at that point, I'll stop share. That's where we are with the presentation. I'm sorry I got so agitated. It's a subject I find very concerning in that I'm coming into an age when I'm going to need, and it's very clear to me that the established structures, methodologies, the administrative processes are simply not up to task. They're not fit for purpose, as the Brits like to say. So with that, I thank you, Brendan. Let's see if we have some questions from the audience. Please share them with us either in the chat, or I guess there's a Q&A space, right, Emily?
Yes, yeah, please enter questions in the Q&A space. We had one participant ask if we will be sharing the study with people on the call, and I just wanted to let everyone know that we will send out the recording as well as the presentation, which has references to everything that was mentioned today. Right. Right. One question: will the new administration continue to push minimum staffing regulations, and what other changes will Trump 2.0 bring?
Well, we know that they're not going to push for the staffing mandate. That's going to be abandoned, whether it be abandoned administratively or through Congress. I guess areas of, and I think that, there's sort of a gotcha, and it was disappointing, but sort of a gotcha mentality under the current administration with respect to nursing homes. And I wouldn't expect to see that, going forward. But there are areas of concern, obviously when you have, this concentration on so-called government waste and this promise to somehow ferret out $2 trillion in savings, you worry about the Medicaid program. And there are those who, are influential with the incoming administration who've advocated for the elimination of provider taxes, for example, which are a means of drawing additional resources from the federal government. And that would obviously be disastrous, as would be any efforts to sort of pare back the matching rate for Medicaid expansion. That then would have implications for states that want to continue serving that population, and that would then bear upon their ability to fund long-term care. And then also the question about Medicare Advantage and just, where that's going. Finally, I would say, I said that Medicare Advantage was an existential threat facing long-term care, but also our immigration impasse is. In the long run, if we do not have immigration reform, we're not going to be able to care for all these folks that Irving was mentioning, because there just simply aren't enough American-born workers to care for aging Americans. That's just as simple as can be, and there's no denying it, and yet we're not coming to terms with that fact.
Thank you. Go ahead, Irving.
Well, in a Trump 2.0 environment, the greatest concern I have is the unleashed power of the insurance industry. So the healthcare lobby in the United States, led by the insurance industry, is the second largest lobby in the in Congress. And because of laws that I don't want to get into, because of political and regulatory issues, money rules, and more so than ever before. I was a lobbyist in Washington for a year and a half. I understand how the machine works, and I know that it requires donations and contributions. But this Citizens United ruling by the Supreme Court has unleashed the money into Congress. And my concern is that the insurance business, which hires and retains many of the smartest people in the room, and hires and retains all of the power of the LLMs and the artificial intelligence, that they'll figure out a way to unleash even more draconian limitations to payments and payment models. What's needed, if I can editorialize for just a few minutes, what's needed is a federal long-term care insurance policy. The biggest single budget crusher in almost every state in these United States is the Medicaid program. And this model was designed as a political compromise, as in 1964-65, as a transition. It's broke. It's a broken model. Brendan mentioned the cross subsidization among nursing homes by Medicare beneficiaries for Medicaid beneficiaries. Technically, that's illegal. That's against the regulations, and yet it's common knowledge that this is what's necessary. We need a transformation of that system into a federal long-term care insurance policy system. And I have another webinar on getting into the nits and the grits of this, is how it would be financed, what it would save the states, how those savings could be recouped. It's not rocket science. Japan has far more difficult aging demographics than the United States. And they implemented a federal long-term care insurance program for its population 14 years ago. If they did it then, we can do it now, and we should. I'll stop.
That's great. No, I agree. And having been a state insurance regulator, I can assure you that to the extent that regulators are even able to regulate, they are completely outgunned by the sophistication of insurance companies.
Great. Thank you. We have another question. How can we put in place the system to train immigrants to provide care in LTC?
Brendan?
Irving?
Okay, so I'll take this one.
I mean, I guess my first question, I don't want to be facetious, but what immigrants? I mean, we're not seeing them right now. They're going to be deported, as I understand it. So,
and the ones who aren't being deported or aren't going to get deported are afraid. Yeah. And they're laying so far below the radar screen. So immigration is a system that's been broken for 40 years, and every administration has kicked the can down the road. Those of us who are old enough to remember, there used to be a particular visa category for nurses. The first thing we've got to do is we've got to reinstate that visa category for foreign nurses. And I would suggest to extend it to other classes of healthcare, licensed and educated healthcare workers, so that anywhere from someone who's licensed in Mexico or Guatemala or Colombia as a nursing assistant, and they have very good education, very good credentialing systems, they are qualified to apply for this visa. And it needs to be opened up in a progressive way, so that we can get back to, at its peak, we were getting 80, 90,000 nurses a year. Most of them are Filipino at the time, and we all have very positive associations with them. They were a tremendous addition to the healthcare system. So that's the first thing we should do. Irving's opinion.
I think that's right on.
All right, this is a long one. Long-standing and entrenched ageist views are an impediment to finding effective policy solutions to quality nursing home supply and to home supports, e.g. universal design. What ideas do you have for identifying a political champion to meaningfully address ageism? While I agree with you that we are a mostly caring nation, I'm not sure I agree that we will pay attention to the suffering and deaths of older people in the coming years and be moved to implement beneficial policies. Thoughts?
Yeah, I share some of that skepticism. I appreciate Irving's perspective, but it is something that we try to remind policymakers here in New Hampshire of the moral dimensions of the question. So we, for example, have the Catholic Charities of New Hampshire as our largest nonprofit member. And they do not hesitate to try to expand upon the moral dimensions of what the Pope would refer to as sort of a throwaway society, where you just cast away those who are aging and infirm. But yeah, I think it really is a challenge. I mean, I've been at this thing for a long time, and for a long time we've been kind of saying, sort of like Paul Revere, but it's the baby boomers are coming, and never seems to wake up policymakers to take the long view, because they're never looking beyond their next election. So And you gotta, in order to have a long-term solution for long-term issues. So yeah, it's I do get worried that we're callous when it comes to the aging.
I I respect those opinions, and I obviously see it differently. I think underneath the weary, uh, inured perspective are a nation of people who care about their neighbors. And all of these issues that we've been talking about are local issues. They are personal issues about with our neighbors. Going back to the first point that this particular commenter raised, ageism is part of a metaphor in the United States, and I do a lot of work in Europe too, the UK, but it's part of the metaphor in the United States and the UK that these places, and I put that in air quotes, these places where people go are only to be tolerated. They're not to be envisioned as anything constructive. They are seen as the end. They are seen as vulnerability, debility, and death. And that is a metaphor and a cultural attitude that needs to be corrected,
Mhm.
needs to be flipped. And I'm in conversation with several people at Nick and other places, a lot of people about how to do that,
Mhm.
how to understand the way we articulate these services, the ageist language that we use, and how that ageist metaphor can be addressed with cultural interventions. There's a huge difference if you're familiar with John Cleese. I'm a big John Cleese fan, at least before he got so old that he became confused. Uh, his Faulty Towers was brilliant, was funny, agonizingly correct. In the United States, Golden Girls is a very good example of congregate seniors housing, where semi-related and unrelated individuals who are age qualified live together. We need solutions that embrace all of that.
Mhm.
And to the underlying point about infrastructure, the current infrastructure in nursing homes is so bad.
Well,
It's yeah, the
we
grunt
don't have
from
anything like
Brendan
the
says.
yeah, we don't have anything like the Hill-Burton Act, where there was a major investment in nursing home infrastructure, hospital infrastructure. Yeah, it is, it was always going to be a recipe for concern, were there to be a airborne pandemic. We knew that. This wasn't a secret, before the COVID-19 pandemic began. Facilities are for the most part old, too crowded. I don't know of any owners who wouldn't prefer to have them be more expansive and have single occupancy rooms wherever possible. But the Medicaid reimbursement simply doesn't support it. It doesn't support renovations. It doesn't support replacement buildings.
Yes, yeah, well said. We have a participant who's actually held up his hand and wants to speak. So I'm going to let this person, ooh, panelists, attendees. Okay. Okay, so Bruce, I think we all know Bruce. Bruce, you're on. Unmute yourself, Bruce.
Bruce, in my experience, is seldom muted, so but he has not unmuted himself.
Okay, you need to unmute yourself, Bruce, if you want to ask your question. Okay, while we're waiting for Bruce to unmute him, there
I
he
think
is.
he's got it.
There he
Yeah.
is.
Okay. I want to go back to Medicare Advantage. We all hate it now as providers. I'm also a user and I love it because it provides so many services that Medicare does not provide. the system as a whole has potential. It's just been warped and twisted in a way that's counterproductive. I think there's a lot of potential for adaptation if we can get by the problems, of course, with the insurance industry, to make that system work to the advantage of people my age, and I'm beyond the baby boomer.
You want to start with that, Brendan?
No, I mean,
Thank
I
you,
think
Bruce.
Bruce is right that a lot of users of Medicare Advantage are pleased with the product. I think one of the things that we do see is that when people are really sick, that's when Medicare Advantage serves them, the least, and they tend to then go to fee for service. So, in that sense, Medicare Advantage is sort of creaming the crop when it comes to the beneficiaries that it's serving. I think that there has been a little bit of movement under the current administration with respect to some of the prior authorization abuses of the insurance companies. Obviously, there's litigation ongoing about the algorithms being used to deny care, for example, skilled nursing care to beneficiaries. I think there need to be reforms that provide for payment floors so that providers can be guaranteed that they're going to get something that's somewhat similar to the fee-for-service rate in order to take these contracts. Because the problem with these contracts is they really can become, as insurers gather more power, more market power, they become contracts of adhesion. There's not, a meeting of the minds. There's not a bargaining power on the part of the provider. It's a take it or leave it situation. And, that ultimately is not good. And it's not good for the beneficiaries either, because then you don't have, an adequate network of opportunities when you need to get medical care. And then, finally, I think the fact that Medicare Advantage was once sold as a savings to the Medicare system, which we now know to be completely laughable. And we're looking at the draining of the Medicare Trust Fund, which I think is expected to run out of funds within the next 10 years. So, again, some reforms need to be done there, because there's some other very expensive therapies that are coming online that Medicare is going to be paying for. Weight loss drugs, for example, absolute budget busters. And I'm not suggesting they shouldn't be paid for by Medicare or by Medicaid. I'm just saying that they're going to be extraordinarily expensive. So we somehow need to bring all of this under control.
Did that answer your question, Bruce?
Pretty much.
Yeah. I'm of a different opinion, Brendan. I have not, since the outset, seen any inherent value in Medicare Advantage. None whatsoever. I knew it was a big giveaway to the insurance industry. They lobbied hard for it, and it's a way of siphoning off public funds into private enterprise. A still further way, ACA started the flow, and Medicare Part C, I choose to call it Medicare Disadvantage.
Yeah.
It has furthered that siphoning.
Well, it's been the subject of a number of my critical law review articles, and I'm trying to be a little polite or optimistic about it. I really am not sure that I am optimistic. We have an incoming CMS administrator who's been a pitchman for Medicare Advantage, owns over $500,000, according to a financial disclosure in United Health Group stock. So we'll see. But, I don't want to leave everybody. I would get accused of being very pessimistic on these types of presentations, and I don't want everybody to just leave feeling despondent. So I'm trying to be optimistic about it. But I do appreciate your point, Irving.
We should do this more often, Bruce, because I could make you look like an optimist. I think the whole thing's going to crash and burn.
I think what we see with Medicare Advantage right now is similar to what was happened in the early days of Medicare and Medicaid in long-term care. There were no rules that can't put any controls on it. at that point. And of course, the reaction is later we had way too many rules. That for Medicare Advantage, there are reasons you can make that work. You've got to make some changes in the system because it provides services that you can't get otherwise if you're old and poor. It's a lot of extra services that they provide. Now, the way it's done is too much of a blank check for the providers, for the insurers, but there's potential there.
Well,
So
yeah,
if I may, Bruce, it's really a false equivalency because Medicare has never, and the administrative cost associated with Medicare has never exceeded 8.4%, I think. Brendan, if you've got a different number, I don't
right.
believe it's ever breached 9%. Insurance industry, at least 20%, at
Mhm.
least, probably higher.
Mhm.
Where's that extra money going? It's going into the pockets of the people who are like the new CMS administrator. It's going into their pockets, and that's public money. So I would suggest the solution here is to divert that money, some portion of that money, to cover hearing tests, to cover eyeglasses, to cover the kinds of things that should be covered for a growing elderly and growingly frail population.
And I've advocated for that. I mean, obviously the things that Bruce would talk about, the extra benefits you can get under an Advantage plan, whether it be hearing coverage, which I think is extremely important to whole body health, or, oral health coverage. I mean, things of that nature, those could all be added to fee for service. And there have been efforts to actually add them to fee for service. In opposition to those efforts has been the insurance industry, because they want to keep those benefits within Medicare Advantage plans.
Right. Okay, I think we have to wind up, don't we, Emily?
We had one person who said Medicare Advantage is an advantage, not to the insured, but is an advantage to the insurers. Agreeing with you in that regard. And one other question, to the previous points, about ageism and changing the perception of facilities. Are you alluding to the broken windows concept for if you make changes to improve the surroundings, that there will be a different perception of the environment?
That's a very, very interesting question. And I've actually written an article about broken windows in long-term care. It's a city planning metaphor that goes back to the early 80s. And we could talk about that, but I think we're out of time. So,
Wrote about
so
broken windows, getting my master's degree in criminal justice. It's a
great.
very applicable to a lot of different things. And but again, yes, I think a subject for another time. But
Another time.
This is
a great point.
another webinar that.
Okay. So I want to thank Brendan so much for a vigorous conversation, excellent conversation, well backed up, factual, and I hope it was helpful. Even if we didn't resolve anything, my hope is that we've perturbed enough to stimulate further conversation. And by the way, with this webinar, as with all of our webinars, if you've asked us a question that we didn't get to, we're going to scrape those questions and we're going to respond to those questions with follow-up messaging and emails. So stay tuned and look for those emails in our in-basket. And if there's anything else that we can do to help or respond or be of service in any way, please feel free to be in touch. Thank you, Emily. Happy birthday.
Thank you.
Thank you, Emily. Happy
Thank you,
birthday.
Brendan.
Thank you, Irving.